مساء الخير على حضراتكم جميعا. أنا آلاء أمجد، مدرس نيورولوجي في جامعة عين شمس. It's an honor to be presenting one of the research projects of our neuromodulation unit in Ain Shams University. It studied the effect of transcranial direct current stimulation on the outcome of patients with acute ischemic middle cerebral artery stroke. As we all know, stroke burden is still very high. It is the second leading cause of mortality and the third leading cause of death and disability all over the world, and the prevalence in Egypt is still very high. Stroke survivors are at high risk of becoming dependent on their caregivers. Many patients are still not candidates for the current reperfusion therapies, and the rate of excellent outcome is still lagging behind the desired percent. So this raised the need for a safe, easily accessible, effective tool that helps to improve the outcome of ischemic stroke patients. An important mechanism in stroke treatment modalities is freezing the penumbra, thus minimizing the energy demand in the already hypoperfused area to try to minimize the area of core infarction. One of the modalities of freezing the penumbra is by inhibiting cortical spreading depression. Cortical spreading depression is an electrophysiological phenomenon characterized by massive, slowly propagating waves of near complete cellular depolarization. It occurs across the cortex at a rate of 3 to 5 millimeters per minute, and these waves start as early as 2 minutes following the severe ischemia. They have been recorded in the penumbra of humans by Domen et al. Since 2008, and it was found that the number of cortical spreading depression was directly proportionate to the final infarct size. One of the methods that are thought to inhibit cortical spreading depression is, in a trial to freeze the penumbra, is the cathodal transcranial direct current stimulation, which is a non-invasive technique. It works through sending constant low amplitude direct currents through electrodes that are placed at specific regions on the skull. Cathodal DCS was also found to reduce glutamate release and thus decrease neuronal activity and metabolism, leading to an overall reduction in oxygen demand and thus better outcomes. Also, various animal stroke models showed very promising results in the setting of acute stroke. One of these translational studies was held in the histology department of Ain Shams University in collaboration with our team, where significant clinical and histological improvement was seen in male albino rats that underwent experimentally induced stroke. Here we see the difference between the sham group or the placebo group. The amount of necrosis is much more significant than the other group on the right side of the screen, in which they received cathodal transcranial direct current stimulation, and the effect was much more better, and the amount of viable brain tissue is much more evident. And thus we made our hypothesis about the use of cathodal transcranial direct current stimulation as a neuroprotective tool in patients with acute ischemic stroke. Our study is a prospective randomized case-controlled study. It included 32 Egyptian patients with MCA strokes who were admitted to our department. It included patients above 18 years old with first ever ischemic MCA stroke. They were presenting in the first 24 hours with an NIH between 5 and 20. We excluded patients who received thrombolysis or thrombectomy, patients with hemorrhagic stroke or consciousness impairment, pregnant females, and any patients with contraindications to MRI or DCS. In the ER, or the first encounter to the patient, all patients underwent baseline examination, CT scan, and received the standard medical treatment, which is the antiplatelets. Then the first MRI scan was obtained, which included the diffusion film. After the informed consent, patients were allocated into the active group or to the sham group randomly. And upon admission, each received 3 ipsilesional transcranial direct current stimulation sessions, each lasting for 20 minutes, using the Caputron Brain Premier device. At day 4 to 7, All patients of both groups had clinical assessment of NIH and MRS scale, and a second MRI scan, including the flare, was obtained. Infarct volume was calculated in milliliters using the MRI Cron neuroimaging analysis software, and infarct growth rate was calculated for all patients. At 3 months post-stroke, MRS and Barthel index of dependency were obtained through a phone interview. As for the results, both active and sham groups were matched as regards the baseline characters, the risk factors, baseline NIH, and the initial infarct volume. The results post-intervention did not reach statistical significance. However, it was notable that the active group showed a tendency toward improvement. This was seen clinically in that the number of patients who had a 30% or more reduction in NIH stroke scale was 3 times more in the active group than in the sham group. Also radiologically, the median volume of infarct growth, representing the difference between the diffusion and post-DCS flare, was 30% lower in the active group than in the sham group. We faced many logistical difficulties during the study: the early admission of patients, the early application of DCS, obtaining the first MRI in the ER within the first 24 hours, and the small sample size. We recommend further research on the effects of DCS on acute ischemic stroke in humans. Larger study sample is required, earlier application of DCS after stroke onset, and also availability of penumbra imaging techniques in the acute setting for research purposes, for more understanding of the penumbra, and potential tools to improve the outcome of acute ischemic stroke patients. Thank you so much. طولنا على حضراتكم.